Okay, now we're going to cover spinal cord injuries. And as we work through this section, I want you to think about what goes on in the acute phase and then think about long term, what changes go on and what you would look for in the rehabilitation phase and then long term management of them at home. So there's a couple of different causes for spinal cord injuries. And it is important that we understand what the cause is from so we can understand the extent of the injury and how we need to assess, and our nursing interventions are going to be depending on the level of the injury. But spinal cord injuries occur from either hyperflexion of the spinal cord, hyperextension, axial loading, or vertical compression, and you can see the examples there caused by jumping, excessive head rotation beyond its range, or something we don't necessarily always think about is because of penetration, and the examples there are like a bullet or a knife, for example. So that's just a visualization of spinal cord injuries where the force causes the head to hyperflex or hyperextend in those two situations, causing damage to the spinal cord, or compression of the spinal cord in this picture here on the right, you can see. And then as a result of compression from the patient falling, or we hear of injuries occurring because of someone diving into water that is too shallow, causing damage to the spinal cord. That's that axial loading that you see, any kind of vertical compression that happens and injures the spinal cord, most likely cervical spine for sure, and possibly down to the lumbar spine. Now, two important concepts that you really need to understand that can happen in someone after they've had a spinal cord injury. Now, these two things that we're fixing to talk about, one is spinal shock, and on the next slide is neurogenic shock. These two things only happen in that initial acute phase of injury to the spinal cord. So this is something that can happen suddenly as a result of injury to the spinal cord. So with spinal shock, we see that it is characterized by decreased reflexes, loss of sensation, and then, of course, flaccid paralysis below the level of the injury. Now, the thing about this is that it usually lasts less than 48 hours, but it may continue for several weeks. So this is when the injury initially occurs and they have that loss of sensation, paralysis below the level of the injury. And at that time, we see those initial responses by the body. But we know that spinal shock, once it resolves, usually within 48 hours, we see what the permanent or long-term damage is going to be. But again, the thing about spinal shock is it can resolve as early as 48 hours out, but we may see symptoms last for several weeks, possibly even a few months. So if a patient has an initial injury, usually the first response is by either the patient or the family is to say, is this the damage, the permanent damage they're going to have forever? Well, you really don't know until that spinal shock has resolved to then be able to determine what are the long-term effects that you'll see as a result of the injury. So make sure you understand spinal shock. And then the next one is neurogenic shock. Now, the thing about neurogenic shock is they have severe vasodilation in the periphery. So they have in their extremities and peripherally, they're going to massively vasodilate. Well, if you massively vasodilate peripherally, then what is that going to do to your blood pressure? Drop it, right? It drops your blood pressure. And then what does that do to your heart rate? It's going to drop your heart rate. So as a result of this massive vasodilation that's going on, their blood pressure drops, their heart rate drops. And because of that, we know that everything's dilating peripherally. Your cardiac output is going to be affected how? Is it going to go up or down? Well, yeah, if I'm peripherally vasodilating, my cardiac output is now going to go down. My cardiac output goes down. So we see that neurogenic shock is very dangerous because of the vasodilation, the decreased cardiac output. And when you decrease your cardiac output, then you have decreased perfusion, which is not good because that's not what we want. We want all of our vital organs to be perfused. So if someone goes into neurogenic shock, what am I going to do? If their blood pressure is low, I can try to reposition them, maintaining spinal stabilization, of course, because we're talking about spinal cord injured patients here. I would want to lower the head of the bed. In other words, reverse, not reverse, I'm sorry, but we would want to put them in Trendelenburg because that way I can maintain spinalization, get their head down. We're going to have to get some fluids. We're going to have to get some medicines on board to get that blood pressure up if it is low enough that their cardiac output is that severely affected. Okay, so neurogenic shock, spinal shock. Spinal shock is not necessarily an emergency, so to speak, but it could be because of the loss of loss of muscle tone and reflexes can cause paralysis of diaphragmatic muscles, which is going to affect their breathing. So if you think of just loss of sensation as not life-threatening, no, it's not. But if the paralysis occurs in an area where it affects muscles for breathing, then yes, spinal shock can be life-threatening. Neurogenic shock, again, we think about your blood pressure, your pulse, everything dropping, your cardiac output going down. And so we know what interventions we can do to contraindicate that and offset that. Now, when you look at a spinal cord injury, it is important that you understand if you are given a clinical situation in the hospital, in the ER, or a scenario on a test question, if it said that the client had a spinal cord at the injury of T2, then you in your mind should immediately visualize where that is in the body and then expect kind of the worst from there down. I would think about, okay, if they had an injury at T2, they're going to have paralysis from at worst case, complete paralysis from that point down. So what does that affect? What does that mean for my patient? So when we look at this picture here, we see your spinal column is divided into cervical vertebrae, thoracic vertebrae, lumbar, and sacral. So obviously, the further down the spinal column the injury is, it's life-threatening. It can be life-threatening and cause a lot of impairment, but when it's higher up, then we know that that is more immediate life-threatening. So if anybody has a cervical injury, we can see the term up there, C4 injury, tetraplegia, which is another term for quadriplegia, all four extremities, results in complete paralysis below the neck. So you see there, if somebody has a C4 injury, are they going to be able to breathe on their own? Probably not. Now, immediately after the injury, I have known people that had injuries at like C4, C5, and they could initially breathe on their own, but then hours into it, because of it paralyzing the diaphragm and the muscles there, the patient started wearing out and they had to be intubated. So if you have a cervical injury and the patient's breathing on their own, you better watch them very closely because more than likely they are not going to be able to support their own airway long term, and you're going to have to intervene. Now we see at C6 results in partial paralysis of hands and arms as well as the lower body. T6, paraplegia, paralysis below the chest. And then you go down further into your lumbar and your sacral. There we're talking about mobility issues for sure. Not worried about any type of airway or respiration when you get into your lumbar and sacral. You're worried more about mobility in the lumbar area. I would think about problems with bowel and bladder because of that injury on down and further down. So to summarize this up, if you have a client that has a injury at T6 or higher, then they are at risk for respiratory compromise. They may initially be breathing on their own and they may do fine for several hours, but watch those patients carefully. Again, if they have an injury T6 and above, then they are at risk for respiratory suppression and respiratory distress and compromise. And that's again because of the paralysis, either complete paralysis or partial paralysis of those muscles that are responsible for our diaphragm being able to breathe. And when I say T6 or higher, don't let that wording confuse you, because if you think T6 or higher, don't think higher the number, because it's actually when you look at thoracic vertebrae, it starts at the top and goes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 down. So that makes sense if I'm talking about T6 right here in the middle, or higher, meaning 1 through 6, not higher numerically, but higher up, then that's the ones that we're talking about at risk for compromise. So when you count your cervical vertebrae, you start at the top and come down. So 1 through 7, we said if they have it at C4, I can guarantee you they're not going to be breathing on their own when they have this injury. They may maintain probably around C4, maybe they can maintain their own for a little while, but probably not but just a few minutes, if that much. And then as we go further down, we said anything above T6 and above, any of the T's and the lower parts of the C's, then you would know that they're at risk for respiratory compromise. So when you get down below T6, we can see just because of the anatomy and where it falls, then that risk that goes down. So you have to understand terms like tetraplegia, paraplegia, quadriplegia, and levels of injury. Make sure you understand that, what you would see. Now, when a patient has an injury, of course, the first thing that we're going to be focusing on is their airway, their breathing pattern, and of course their circulatory status and what that's doing, because we already said we know that they can go into neurogenic shock, which is not good. Anytime somebody has a spinal cord injury, of course, you're going to assess them for any other injury that they may have. So it talks about looking for intra-abdominal hemorrhage or hemorrhage, bleeding around any kind of fracture site that they may have. Check their level of consciousness using the Glasgow Coma Scale, and you're very familiar with that. And here it is again, the level of injury: tetraplegia, quadriplegia, quadriparesis, paraplegia, and paraparesis. Obviously, the priority is going to be the potential for respiratory distress or failure. Again, that's going to depend on where the level of the injury is as to their risk or their potential for respiratory distress, potential for cardiovascular instability. So there's that shock, and that can be neurogenic shock, or maybe just hypovolemic shock if they had another injury that's causing loss of volume or blood. And then we're going to talk about autonomic dysreflexia in a minute, because that is something that they can have problems with forever after a spinal cord injury. And then, of course, the potential for secondary spinal cord injury because of the inflammation and swelling and possibly bleeding around the site and damage that's going on. Decreased mobility and sensation. That just makes sense why they would have that. Managing their airway. Maybe they can manage it on their own. They may need to be intubated. Of course, monitoring for cardiovascular instability. I think by now, after going through cardiac, y'all all would know what signs and symptoms to look for to see if someone's cardiovascular status was unstable. Prevent secondary spinal cord injury, and that's just by maintaining spinal stabilization when we position or have to move this client. Maintain mobility. They may do that through non-surgical management. We're going to talk about some ways that they do that: immobilization, drug therapy, and they may have to have surgery done, some type of spinal fusion or some procedure done to maintain the stability of the injured area. Okay, so you can see the next several slides, we've got it divided up by body systems, and that's how I want you to think about somebody who's had a spinal cord injury, how that body system is affected acutely in that initial immediate phase, and then more long-term management of potential problems or problems in that particular body system. So again, it just depends on the level of the injury as to what you're going to see. If you had somebody that came in with a T12 injury, your respiratory system is not going to be your priority because that's so far down that it's not going to affect that respiratory drive. So we said above level of C4, total loss of respiratory muscle and function, they're going to require some type of mechanical ventilation. Below the level of C4, they're going to have impairment of the diaphragmatic breathing. So anywhere from C4 down to T6, those are the ones you better watch because more than likely they're going to be insufficient in their own respiratory drive and are going to start crashing on you. So immediately, that's what we're worried about, very acutely. And then as we switch gears and think about long-term management of somebody with an injury, it depends on the level of the injury again. If they have a cervical injury, we said anything above C4, they're going to be permanently on ventilatory support. Anything between C4 and T6, they may temporarily be on ventilatory support. But then when I think about longer term management, once they're off the ventilator, we're going to, because of that injury, they're going to have weakened muscles, potentially total paralysis of muscles in certain areas that would normally help them to cough and deep breathe. So respiratory therapy is going to play a really important part in coming in and teaching these patients how to effectively cough, deep breathe. This increases their risk for infection. So avoiding crowds, they're going to be more susceptible to infections. So long-term management, you see, is going to be a little bit challenging for them in their respiratory system, depending on how compromised they are with that. And it really depends, again, on the level of the injury. Your book shows a picture on page 898 of an individual having to have cough assist, and it is a technique that is used in patients that have the higher spinal cord injury where they are unable to, unlike you or I, who do not have a spinal cord injury, we can effectively cough and clear our secretions, but they're going to need some assistance. And you can see in that picture how you're placing your hand over them and providing pressure while they cough, and that just helps them to make their cough more effective. So that's called a cough assist. You may see that terminology from time to time. Okay, now as we move on down and look at the cardiovascular system, of course, we already said that initially we are going to be worried about the development of neurogenic shock, right? We said that that's a possibility that can happen after the injury, so we know how we would monitor for that. We are going to look at their blood pressure. Are they having that peripheral vasodilation? Are they becoming hypotensive? Are they becoming bradycardic? Put them on a cardiac monitor as a result of their injury. We may have to give them medicines like atropine to get their heart rate up because of this peripheral vasodilation that's going on. And because of that, we said it's going to affect their cardiac output. So we may see that we have to give them fluids or even vasopressant medications to get that blood pressure back up. So just very close monitoring of them with their cardiac status, putting them on a cardiac monitor, continually watching that blood pressure, watching their heart rate, and assessing for any signs of neurogenic shock, and intervening with fluids, positioning, maintaining spinal stabilization, vasopressant medications to get that blood pressure up and to get that heart rate up. Of course, once they've stabilized, usually after 48 hours, we still are going to monitor their cardiovascular system, and we know that they are at risk for like orthostatic hypotension, long term, even months or years after they've had their event because of the injury. So we have to turn their position really carefully, really slowly, even like long term after they've had their injury, because of the hypotensive effect that it can have just from orthostatic, their body changes. And that would be something we'd look for more long term. And then, of course, with the cardiovascular system long term, I would think of because of paralysis and loss of the ability to move from the injury down, you're at risk for DVTs. And so you know all of the parameters and the interventions you would do to help prevent someone from developing a DVT because of that decreased mobility that they have. So when we move on down the urinary system, of course, in the acute phase, they are going to more than likely have urinary retention. So it would not be uncommon in the acute phase of them having their injury that we put an indwelling catheter in to manage that. But then it depends on the level of the injury and how affected their bladder is. But if we're going to think worst case that they are unable to empty their bladder, then we're going to need to start them on a bladder training program. This person will need some type of medications to help them manage bladder spasms. They are going to need to self-catheterize at regular intervals that are scheduled throughout the day. We do not want any distension of the bladder because that can trigger autonomic dysreflexia, which is not good. So the bladder may become hyper irritable, or it may lose tone and they may develop what's called a reflex bladder, which means when their bladder will just spontaneously empty. The bad thing about that is it does not completely empty. And we know when the bladder does not completely empty, then you have retention of some urine there, which we know can cause them to have bladder infections. So we're going to need to put them on some type of urinary program. Don't be surprised, like I said, if they are on some medicines to help relax their bladder. We will need to do routine, scheduled self-catheterizations. So they've determined that in and out catheterizations are better than if they were to leave an indwelling catheter in place forever and ever and ever. Now, another option for some, if they have a reflex bladder, is the use, if it's a male, the use of a condom catheterization. But again, that would just be for the reflexive purpose of the bladder. More than likely, they're going to need regular in and out self catheterizations, or depends on the level of their injury, their caregiver may have to be taught how to do in and out catheterizations. Now, when we look at the GI tract, there are some things that go on. If you think about, those patients that we said may develop neurogenic shock, the peripheral vasodilation, decreased cardiac output, and just as a normal stress response, what does your gut tend to do anytime it's stressed? Yeah, it wants to shut down, right? So we would need to monitor these patients carefully. If their gut shuts down, what are they going to develop? What's the word? That's right, a paralytic ileus. So they may develop a paralytic ileus. So I wouldn't be surprised if they possibly in the acute phase put an NG tube down, monitor those bowel sounds very carefully, very closely, because we know that as a result of their gut slowing down, peristalsis is going to slow down also. It may potentially stop. That would be the worst case scenario, is that it stops. So they may put down an NG tube initially for decompression of the stomach, and they're going to be on some medications to help with the prevention of stress ulcers. Anytime the body undergoes a major stressor, that patient is at risk for developing a stress ulcer or a Curling's ulcer. You may have heard it called that. So they're probably going to be placed on some medications, some PPI, some H2 antagonists. So don't be surprised if we see the use of those with their care. Now, longer term, we are going to need to place them on some type of bowel program. So here you want to consult with dietary to have them placed on a diet that is going to encourage the use of fiber, but we do not want to use any types of gas. We want them to learn how to stay away from foods that produce a lot of gas. We will probably see the use of some type of stool softener for them every single day. There's going to be some type of bowel evacuation program that they're more than likely going to need to learn how to do, whether that's the use of a suppository or a small enema every other day, whatever their bowel pattern works best for them, because we do not want them to become constipated or worst case impacted, because if their bowel becomes distended, then that increases their chance of developing autonomic dysreflexia, which is not good. So immediate, we're worried about the bowel just slowing down and the potential for a paralytic ileus, so we know how to look for that, and we know how we would manage that if the patient did develop a paralytic ileus. We talked about ulcers and stress and response on the gut, and then longer term, we've got to put them on some type of bowel program, including diet and the use of probably stool softeners daily, and then use of some type of either digital stimulation, a suppository, or a small enema to help them have bowel evacuation if they've lost that tone because of the level of their injury. Now, when we look at their skin, I think about, usually spinal cord injuries are internal, so there's not like a tear in the skin or anything like that. So it makes me think of more longer term damage that occurs to their skin because of the immobility. And so that puts them at risk for skin breakdown. So turning, repositioning. Of course, initially, after that initial injury, we're so focused on maintaining spinal stabilization that it may be extremely difficult for us to turn and reposition this bed while maintaining that stabilization until they have done some type of intervention to stabilize the spinal column so that we can adequately turn and reposition and move them in the bed. One thing that we do see in our spinal cord injured patients is the development of poikilothermism. POIKILOTHERMISM. And so they have this interruption of their central nervous system, so they have the decreased ability to sweat or shiver. And we do see this more commonly in your spinal cord, in your your high cervical injuries. So they if you see this, they'll like break out in goosebumps. Then we know that we need to cover them up. They are impaired with their shivering and sweating capabilities, so we have to address that for them. So long-term management as far as their skin goes, they're going to need like daily skin inspections from head to toe because of the either complete loss of sensation or decrease in sensation that increases their risk for skin breakdown. So we need them to assess their skin regularly or have a caregiver make sure that they assess their skin regularly and identify any potential for skin breakdown early. Okay, let's talk about metabolic needs. Now, initially we said that if they have developed a paralytic ileus, they may have an NG tube that's hooked up to suction. So that places them at risk for some electrolyte imbalances. If we are having to suction out their stomach, then we are suctioning out the acid in their stomach. So that increases their risk for developing what acid-base imbalance? That's right, metabolic alkalosis. They're at risk for metabolic acid alkalosis because think about it, it's like somebody vomiting all the time. Anytime somebody's vomiting a lot or an NG tube hooked up to suction, that places them at risk for metabolic alkalosis. Now, after that has resolved, and let's say that their gut is back normal, then usually within 2 to 3 days after their injury, if their gut is responding okay, then we need to address those nutritional needs. They need high protein. Of course, if they're in such a critical state that they can't consume foods normally, then we would have to use some type of supplemental feeding, whether that's through an NG, potentially longer term through a PEG, maybe very short term. If their gut's not working, they may be on TPN or Hyperal, but that would just be very short term, just initially to meet those metabolic demands and needs that they require. But then long term, when I think about metabolic needs, I really just think about addressing nutrition for them, and I think about if they have any breakdown or areas, high protein, incorporating fibrous foods, but not gas-producing foods, but things with fiber and protein that will keep their bowels and everything regulated. Kind of mentioned this earlier when we were talking about the cardiovascular system. As far as peripheral vascularly, we said initially they can have that peripheral vasodilation and congestion in their extremities, but I really think about as far as the spinal cord injured patient with their peripheral vascular system developing a DVT or a VTE, which kind of encompasses your DVTs and your PEs. They just have some type of VTE, a venous thrombolytic event. So we would see the use of TED hose on this individual to prevent a DVT. They may use the sequential compression devices on their extremities, range of motion, moving them in the bed, anything to prevent venous stasis, which we know is going to promote a DVT, which could break off and then go to their lungs and cause a PE, which we don't want. So in order to prevent that, we talked about moving and things like that, but don't be surprised if you see this person placed on a thrombolytic agent to prevent them from developing a DVT. And we would need to educate them on why they're having to now use this therapy, and maybe something they have to stick to long term because of the risk of developing DVTs. So now let's talk about one major concern that can develop in our clients who have a spinal cord injury, and that is autonomic dysreflexia. Now, this is something that they are at risk for forever after having their spinal cord injury. This occurs when someone has a higher level spinal cord injury. You have a box or a chart on page 896 in your book that has some key features of autonomic dysreflexia. So this is when you can see that they have a sudden significant rise in their blood pressure and their heart rate drops. So it's classified by, their blood pressure just shoots up extremely high. This could be considered a hypertensive. They could have, as a result of autonomic dysreflexia, a hypertensive stroke. So this is something that is life-threatening that can happen. Another key feature you see is profuse sweating above the level of the lesion. So they'll usually just complain of a severe headache. They may or may not know that their blood pressure is elevated, and they'll just break out in a sweat above the level of the injury. And then you see goosebumps above or possibly below the level of the lesion, flushing of the skin above the level of the lesion. Your client may complain of blurred vision or spots that they see in their visual field. They may have the nasal congestion that develops. There's that throbbing headache and flushing above the level of the lesion with pale skin below the level of the lesion. So this is an emergency that we need to make sure we intervene quickly. Now, if someone is experiencing autonomic dysreflexia, it's because something has triggered that response. So you can see on this picture some very common causes of that triggered response that causes this autonomic dysreflexia. And you see there something as simple as restrictive clothing. It could be a sock that's too tight on their foot or their ankle, or their shoe is tied too tight, or their belt is on too tight. You see in your picture pressure areas. When you or I, who do not have a spinal cord injury, when we're sitting or lying in the bed, when we get uncomfortable, we move. So when they have this injury, they can't sense that uncomfortable feeling that makes them need to move. And so it's trying to send a signal up to the brain to tell the person that they need to move, but because of the injury, the message doesn't get sent and it just kind of bounces back and goes down. And so it's because of that irritation that causes this body's response where the blood pressure shoots up, heart rate goes down. If we can relieve whatever is causing the irritation, then it's going to cause that blood pressure to go down and it's going to cause their heart rate to come up. We can see a full bladder, even a UTI, distension in their bowels, so being impacted or being constipated. So we want to do everything that we can to avoid autonomic dysreflexia, and it's because of some kind of trigger that's done that. If they have an indwelling catheter, check and make sure that that indwelling catheter tubing is not kinked in any kind of way that's causing their bladder to fill up. Look for wrinkles in the sheets. Look for the client to be possibly laying on something. Maybe they're laying on top of their indwelling catheter tube. We have all seen patients that we've taken care of that were laying in the bed, and we went to turn them or reposition them and we found things up under them. Well, for a spinal cord injured patient, that could be life-threatening. If you trigger this autonomic dysreflexia, not knowing that they're lying on a syringe cap that was accidentally left in the bed, causing a little pressure and irritation on them, then they could have a hypertensive stroke as a result of it. So we've got to remove the stimulus, remove the irritation, whatever's causing it. And by just removing that, then their blood pressure is going to come down, their heart rate's going to come back up, and they will recover from the event that has happened. So again, prevention is key with autonomic dysreflexia. If by removing the stimulus, their blood pressure for some reason does not come down, then we may have to give them a single dose of a medication in order to get their blood pressure to come down. But that, it can happen, but most autonomic dysreflexia symptoms can be resolved by treating the underlying trigger. Sometimes I've heard patients say that they went into autonomic dysreflexia because of a draft that came through in the room and it caused an irritation on their skin. So anyway, those are the symptoms, and that's what we would look for, and we want to avoid it when possible. Now, here are just a few examples, and when I think about these examples here of a cervical collar, that's just initially after the injury, or we may see patients wearing cervical collars for a little bit longer after the injury. And in the right hand side, there's a picture of a patient wearing a halo vest. There are some precautions we have to take with that. Maintaining spinal stabilization, it depends on the person. They may require surgery. We talked about that. Then they may have a cervical. They may have some surgical intervention that they have gone through to maintain spinal stabilization. Initially, they may have some type of traction. Y'all have probably addressed taking care of somebody who is in traction. Makes me think about patients who have hip fractures. We put them in Buck's traction. Here we are talking about the cervical column, the spinal column, so we are trying to maintain stabilization. If they have a halo vest, which is the picture on the right, this is for long-term stabilization that is going to be needed for this patient. You've got a good box in your book. Actually, you've got two areas in your book on page 899 that I'm going to refer you to. There is a yellow box that goes over the nursing safety priorities for somebody who has a halo device. And at the very bottom, there are some patient and family educational things that we need to educate them on if they're going to go home. Well, they will be going home with the halo device. So make sure you read over those. They've got some really good, very pertinent information that you'll find useful. Now, we've kind of worked through these as we've gone through each body system, and we've talked about how the injury affects that body system acutely, and then we've looked at long-term. So we have to address the fact of them going home and their home care management. Do they have somebody that's going to be able to take care of them? What are the accommodations like in their home? Is their home going to have to be modified some kind of way in order for them to now have equipment, bed, wheelchair accessible? So home care management may be a challenge for them, and we'll need some resources. So this would be a great time for you to get your caseworker involved to provide those resources and support for the patient, their caregivers, for very long term for this individual. So when we talk about self-management and education, these are things and important information that we're going to need to give them so that they know how to manage these things long term from here on out. When I think about mobility skills, I think about utilization of your physical therapist to help them be able to maintain mobility and independence. We want to try to promote as high as level of a function as this person can. Of course, pressure ulcer prevention, we need to educate them on that. We've already talked about bowel and bladder program. Sexuality, we did not address that, so let's talk about that for just a minute, because it depends on the spinal cord injury and the level of it as to how much impairment they have with sexuality. That's a concern for a lot of individuals. Just know that that would be individualized for that person, depending on the level of injury and the impairment that they have. But there are a lot of different options and methods that are available for them to use. We may have to use in our patients some medications to help because of the impairment with nerves and circulation to their anatomy with their sexuality. So we may see that being a concern and some education that we'll have to give them and being individualized for the person. And then healthcare resources, whether they're going to need home help, social services, care outside of the home, outside the hospital once they go home. Let's look at a couple of situations that we've got here. And so looking at this, what did you say? Which assessment were you going to perform first? Well, this one's easy, right? Airway is always number one. So even if they do not appear in any kind of distress, he says that his neck hurts. That concerns me, knowing that he had an injury and his neck is hurting. So we got to assess that airway. All the other things can be addressed after we assess their airway. All right, let's look at this. What are we worried about here? That's right, number B, because we know anytime somebody's blood pressure gets to 90, I am thinking that they are not perfusing adequately. Anytime somebody's blood pressure gets to 90 and below, I'm worried about perfusion. The fact that they have an unresolved headache is a concern. It's not something I necessarily would immediately go and report. A neck pain of 5, I don't want them to have any pain, but they just were involved in an MVA. And the fact that they have pain is not necessarily uncommon. The fact that they have an increase in their Glasgow Coma Scale is good. That's a good thing. I want to see that happen. So our patient gets admitted to the ortho unit. They have loss of motor function, pain, temperature sensation. Now this is not something I'm going to test you on, but this is just a question scenario that I got off of a educational site. So here the answer is B, an anterior cord syndrome. That's what we are seeing in this scenario. All right, let's see what's going on here. Heart rate 48, blood pressure is 78/66. What are we worried about? Perfusion, right? So what is the best action? Well, first of all, raising the head of the bed is not going to do anything to their blood pressure. If anything, we need to lower the head of the bed, right? Is applying oxygen at 2 liters going to help? No. Increasing the rate from 50 to 75 is not going to help. So what we're going to do is A, notify the healthcare provider immediately. We need some help. 10 days later, they're getting discharged to a rehab facility, so the nurse understands which to be realistic approaches. We want them to do which ones? A, yes, we need to do A. We need to do teaching them self-care skills. What about B? Yes, we're going to do B. We want them to be as independent as possible, so we're going to work on those mobility skills. What about C? Yes, bowel and bladder retraining. We've talked about that being something they need to address. Do you think in option D that they're going to be able to return to their pre-injury status? No, that is not a realistic approach. We want them to maintain as much of a level of functioning as they can, but are they going to be able to return to pre-injury status? That's not a realistic goal in that initial rehabilitation phase. We could do that longer term, but not initially. And that's what it's asking us, initial. And then training caregivers to take over the patient's care. No, we don't want them to take over the patient's care. We want the client to be involved and maintain as much independence as possible, which is going to help their self-esteem and make them feel better. All right, here we go. What is the priority assessment question that you wanted to ask them? C, that's right. Tell me about your pain and what interventions are helpful in managing. Having them tell us about their pain opens the question up for them to elaborate on. Option A, how long have you had your back pain? They could answer that just by, 3 weeks. And that's all they're going to say. So, B, how does your back pain affect your activities of daily living? That may be something we want to know, but C is very conclusive. It gives us a lot of information. They're going to tell us about their pain, how it came on, how it makes them feel, and what they're doing to manage their pain. And then option D is just kind of a yes/no. Sudden severe headache, C5, C6, they're flushed, vital signs, their blood pressure's gone up, their heart rate's gone down. We know what this patient is experiencing, which is autonomic dysreflexia, right? Autonomic dysreflexia. So what are we going to do? What is the first thing we're going to do? We're going to sit them up, okay? We're going to sit them up. By sitting them up, that's going to lower that blood pressure. If we lay them down, that's going to make their blood pressure worse, cause them to have a hypertensive stroke. So the priority, the first thing I'm going to do is sit them up. Now, are there triggers that can cause them to go into autonomic dysreflexia? Yes. So if you picked C or D, these are causes, but how could you pick one over the other? Because they're equally important. You can't. You couldn't pick C over D because they're both triggers. This is not something we're going to notify the healthcare provider about. Maybe later after it's resolved we could tell them, but putting them up in a sitting position is going to lower that blood pressure, and then we can look for triggers or causes in that patient. So just know with autonomic dysreflexia, the very first thing that I would do, and your book tells you to do this when they have autonomic dysreflexia, is you want to sit them up. And then after you sit them up, you are going to look for the cause and eliminate the cause that triggered that autonomic dysreflexia.